What?
Hi, my name is Emerson Ipsen, and me and my partner Aubrey are presenting on somatic symptom and related disorders. So, somatic symptom and related disorders are defined in the DSM-5 as diagnosed on the basis of positive symptoms from either the somatic physical stressors and the abnormal thoughts, feelings, and behaviors in response to them. This has recently been changed because prior to the change, the DSM defined it as the absence of an actual medical condition and then the psychological distress in spite of there being no condition. We've moved toward assuming that the individual may or may not experience real medical distress. So, just some risk factors to consider for developing somatic symptoms and related disorders. There's the genetic and biological piece, increased sensitivity to pain, and the personality trait known as neuroticism more make people more vulnerable to having somatic symptom disorders. Second one is trauma. Exposure to violence, abuse, or deprivation in early experiences can lead to the development of a somatic disorder. And then there is also the social and cultural piece, at where in some cultures, physical pain is reinforced as more valid than psychological pain, and stigma around the psychological pain or the mental illnesses may also lead to physical symptoms being more respected and externalized as the pain. So there are six diagnoses under the general somatic symptom disorder diagnosis. The first one is illness anxiety disorder. Second is functional neurological symptom disorder or conversion disorder. The third one is psychological factors affecting other medical conditions. The fourth one is factitious disorder. The fifth one is other specified somatic symptom and related disorder. And the sixth is unspecified symptom and related disorder. So, Aubrey and I had each picked two diagnoses under the somatic symptom and related disorders. The one I chose is factitious disorder, which is a pretty commonly known about disorder. It was previously known as Munchausen syndrome or Munchausen syndrome by proxy. The primary feature is that the individual is falsifying medical or psychological symptoms, even if they're alone and in their private lives, they're continuing to reinforce that they have the psychological or physical symptoms of the illness or condition. It can be imposed on the self or others. Methods for fabrication and falsification include exaggerating, fabricating, simulating, and inducing. So, actually physically injuring or getting yourself sick or another person, which leads into a real life connection on the next slide. Um, some of you might be familiar with the case of Gypsy Rose Blanchard. In 2015, Gypsy ended her mother's life by conspiring with her boyfriend. And through her testimony, as well as her other family members, the pieces come together to show that Gypsy's mom had Munchausen syndrome by proxy, otherwise now known as factitious disorder. She would induce illnesses and conditions on her daughter, including but not limited to cancer, blindness, inability to walk. She had feeding tubes put on her otherwise healthy daughter, as well as saying that she was younger and also delayed. This is a really good example of factitious disorder that is uh, induced on others or inflicted on others. But there's also the possibility for one to inflict it on themselves. So yeah, that's just a good practical application for it.
Okay, conversion disorder. Um, so conversion disorder, primary features of this disorder are it's basically psychological stress is converted into neurological distress, as seen in symptoms like seizures, paralysis, and blindness. Whether when there's no other known physiological cause. Neurological symptoms can include weakness or paralysis, abnormal movements, tremors, gait disorder, trouble swallowing, troubles with speech, seizures, anesthesia, sensory loss, loss of oneself, or a mix of symptoms. So basically, your body has a lot of trauma or distress and it doesn't know what to do. And so, yeah, it converts it into physiological stress. So, the reason I chose this disorder is because I have a close family member who experiences this disorder. It is not a common disorder. So, I was able to interview her about her experience. And with her permission and her name change for privacy, I wanted to include tidbits of her perspective while reviewing this disorder. For the purpose of this presentation, her name has been changed to Irene. So, Irene's story. So Irene experienced a trauma-intense childhood in which she first started experiencing memory loss and seizure-like symptoms. In her early 20s, she started experiencing more intense seizures. She was diagnosed with epilepsy at first, and they put her on a really intensive seizure medication. 15 years later, the medication slowly stopped working and the side effects became too much. She saw another doctor and completed an EEG, through which she was diagnosed with conversion disorder. After seeing a therapist and a breathing coach, her seizures have nearly disappeared and are extremely manageable through breathwork and grounding. Um, so just some kind of critiques of this disorder. A lot of pediatric patients with vague symptoms are at risk of being diagnosed with this. And one study that I saw, a lot of kids with Ehlers-Danlos syndrome can be diagnosed with this, which can build distrust between the client and the medical provider if this is the wrong diagnosis. We also don't fully understand the reasons behind why our body converts psychological stress into physiological stress sometimes. Um, Sometimes, even if we can't find a physiological cause, and we diagnose that someone with conversion disorder, even it's usually therapy can be very helpful for folks with conversion disorder, but sometimes even if they go to therapy, the symptoms won't disappear or lessen. And then just kind of a little insight I got from Irene on this. A lot of doctors don't even consider this to be a real disorder because it's so new and it can delay diagnosis and life-changing intervention, which is kind of what happened to Irene. So just a little tidbit about maybe a cultural difference you might see on this one. This is mentioned in the DSM, La Belle Indifference. This phrase is of French origin and directly translates to beautiful indifference. It's often used in Western countries, but you'll see it especially in Europe. And it states that it is meant to be a lack of concern about the nature or implications associated with the symptoms. So basically, just that people who have conversion disorder, they might say that person has la belle indifference. So researching it further, the phrase is often thrown around to say that again, someone doesn't they feel indifferent about their condition, and it's often connected to conversion disorder, although it is not always connected directly to that. And then just reviewing some cultural factors in general of this category of our somatic symptom disorders. Um, So cultures like have different views on these types of illnesses. Of course, a lot of cultures, like in Asian culture, specifically East Asian culture, they tend to have higher rates of this disorder. And it tends to present in more of a physical way, so things like seizures, as opposed to things like trouble swallowing, um, or just, some of the other symptoms that one might experience. There's also a much higher rate of this in Latin cultures. They tend to have the highest rate of somatic symptom disorders. So that's something to look for within marginalized communities. As far as gender differences, for the most part, women experience more somatic symptom disorders than men. And then for social support and stigma, again, a lot of people don't see these disorders as real or may think that the client or the patient is lying. And so a lot of times there's not a large amount of support for people who experience these things, and they can often be written off as, a hypochondriac, or you're just faking it, things like that. Or people just don't take it very seriously in general. So, questions to consider. So, for factitious disorder, what extent are those with factitious disorder accountable for the harm caused to themselves or others? Should jail time or rehabilitation be involved in appropriate cases? How can we better recognize conversion disorder? What could be further research to further prove this is a real disorder people experience? And then conclusion, if a client has a somatic symptom related diagnosis, it is not up to us to determine whether or not the pain or symptoms they're experiencing are real. We should always treat it as real, and with help from medical professionals, we can get closer to providing the client with the correct diagnosis, whether it is psychological or physiological or both. A correct diagnosis can lead to a life-changing intervention. And here are our references. Yay. Let's see if I can figure out how to stop.